welcome. Okay. Thank you so much. I know it's Friday and it has been a very long day. Inshallah, my presentation will be very swift and very easy. I'll just reflect on so many points that has been done or covered by our colleagues. So I will be talking about next generation value-based payment strategy, but, and this is my conflict. I'm not sure if, this is my conflict of interest, so I don't have any real or potential conflict, and I'm not representing any governmental entities in this talk. Okay, let's just shift gears here a bit. I just want to highlight or make sure that we're all, again, are very, we know that what are the three key pillars when it comes to the transformation in 2030. So definitely thriving economy. By what? By increasing the private sector to contribute more than 65% of our GDP. Ambitious nation, by creating a high, efficient, transparent, and accountable government, and vibrant society, making a vibrant society with strong roots. And one of the keys here is increase life expectancy by 80 years. And this definitely will have our healthcare expenditure increase even more. Now, the three objectives when it comes to health is improve health, as we said, increase the life expectancy, improve healthcare by improving quality and ensure consistency of services, and improve value. We know that we have cost containment, we need to improve outcomes, we need to control public healthcare expenditure, and we need to guide new investments as well. Why do we need the transformation? We all share here the same pain. All healthcare sectors share this same pain. So we know that we are increasing population. We know that we have an increased prevalence of chronic disease, and this is what we are impacting now, since we are one of the rules or one of the outcomes is to increase our life expectancy. We know that there is a very high, expensive medication is being launched, and we all share the same pain again in increasing the cost, and we have the cost containment when it comes to adoption or accessing of certain line of medications. And most importantly, we all have uncertainties when it comes to these new innovative medication or interventions. So again, this is the total population. In 2021, Saudi Arabia is reached to 34 million, and it's expected to be in 2100 reaching to 50 million in population. And this is what we need to focus on, is the population. We are young society now. Currently, we're a young society. But in 2100, this graph will be upside down, having the population majority from 25 to 64 is in the light blue color, and more than 65 is the purple color. And those two, let's say, population will have an increase in our expenditure when it comes to healthcare. Again, these are the market innovation when it comes to new innovation of launching of new medications, and their price tags in launching of these products. This is one. I'm going to share just one or two examples on certain medications, especially when it comes to immunology, dermatology. One of the products that we have recently evaluated, it cost about 100 million Saudi riyal inflation over 5 years, and this is only one medication. When we are talking about only subcategory with severe cases that we will be eligible to treat, and yet the inflation was to about 100 million Saudi riyals. Now, in 2015, this is just a screenshot of cell and gene RNA therapy global sale. So it increases from 2015 being 22% up to, in 2019, 65%, and it's increasing. And this is just not reflecting the different pipeline medication that's coming in our way. So we cannot keep doing what we're doing lately. And just introducing a new medication, getting to the formulary, having access, but still we know that we are increasing population and still we have cost containment. Okay, so this is basically what we've been doing in the last 4 years. So when we say managed entry agreements or innovative contracting, so we have two models, financial-based and value-based, but we at MOH, we focus on the value-based. Does not mean that the financial base is not being needed. Relax. This is a basic or fundamental thing, but it is not under our, let's say, negotiation. This part takes care of it by NIBCO. So when we talk about value-based, so we provide, when we, let's say, have this dialogue with our pharma industry, they know that we ask for two things. We need to pay for what does actually work. So we have a scheme of patients, what are the patients who will be eligible, and then if the patient's failure, what is the rebate for those failures, and then we need to provide or generate real-world data. So this is what we are doing. We create a state-of-art registries, electronic registries, and follow our patient across different sectors. Again, this was last, let's say, from until 2016-17, that it has been changed from being volume-based to a value-based, and we have driving factors, again, innovative medication and very high costs of these medications, and the requirement for health outcomes as a KPIs. This slide shows you what are the medications that we really focus on when we talk about managed entry agreement. So managed entry agreement proposals or innovative contracted does not meet with all medications. It needs to be for our addressing some medications. We are genetic disorders, hematology, oncology, and neurology. These are some examples that we currently having at the Ministry of Health. Okay, this was addressed by Dr. Judea, but it's very important to understand why we are doing this and who are the stakeholders which benefits from all these, let's say, follow-ups or the managed entry agreements or innovative contracting. So patients will be able to have an access or easy access or fast access of these medications. Providers will generate knowledge and improve disease management, as Dr. Hajer was saying, that we are seeing different cases and different patients that we were not usually seen by clinics. So this is one very important thing that we are capturing during our practice, reducing, of course, the uncertainty when it comes to effectiveness. Governmentals and regulators, again, we're limiting uncertainties. We're improving the outcomes and quality of life. When it comes to payers, we ensure them that they pay only for something that works. The manufacturer, again, expedite access, and we are pushing or nudging toward the R&D stimulation. Okay, this is just to, again, was highlighted by Dr. Hajer, just this to show you what are the components of different managed entry agreement that we do. So it definitely contains clinical, it definitely contains financial, and services, as we said, that we do have registries, and implementation of these registries is a part of having any managed entry agreement to be done. So this is just a screenshot to show you where is Saudi Arabia now situated with all the value-based agreement has been across the world. Alhamdulillah, we reached about 28 contracts. 17 was on the, outcome-based, and the remaining was a financial-based. These are just something that we are now exploring. when we talk about different new or innovative contracting, Netflix subscription-based model. This is one of the new models that we are currently studying or working around it. This was reflected or talked about Dr. Judea when he was talking about the accountable care organizations and the pool funding, bundle payment as well. This is just to ensure what are the outcomes for getting these, let's say, managed entry agreement, because these proposals took us, the first one took us about more than 2 years, but alhamdulillah, and then we start picking it up, because something new, you will face different challenges from different angles when you come to implementation. But now, we finalize it within 3 or 4 months, alhamdulillah, and we make sure that the infrastructure and capabilities building improve disease management and health outcome, and risk sharing, limiting uncertainties. These are all something that we witness every day when we are trying to review or having our reports from these registries. And by this, we are achieving a value-based healthcare, which is the transformation in healthcare. This is our first, and it is the first, I think, policy that has been shared when it comes to managed entry agreement, reflects all rules and responsibilities of stakeholders involved, and the level of their responsibilities as well, and has been published on our website, Ministry of Health website. I just want to share one of the, let's say, exercises or one of the agreements that we have shared with our, one of the medications that we are currently reviewing. So again, our managed entry agreement ranges between 2 to 3 years, and if there is any, let's say, follow-ups, so as one of the medication that we have, the duration is 7 years, so we have 2 years enrollment and then 5 years follow-up, so a total of 7 years. And then we limit the patient eligibility, so we have, let's say, eligibility of who will be eligible for taking the medication, because it needs to be an open dialogue with us and the pharma industry, understanding who are the patients that will be eligible for medication, and for us to assess and understand what is the outcomes that we wanted to see from these medications. And then if the patient did not, let's say, or tagged as patient that did not failure or did not benefit from the medication, then a full compensation of the vials or that is consumed by the patients. And then again, we have a free initiation, one of the financial, let's say, part when we do our evaluation. So this is one. And additional services, as I said, any managed entry agreement needs to be coupled with a registry for us to generate real-world data and making sure that these medication, how is this medication works with our population. This is another thing, another example, again, with spinal muscular atrophy, and this is the one I was mentioning earlier. It is 7 years, 2 years enrollment, and then 5 years. And the innovation here is we are going into installments, so we don't pay the full amount upfront. We pay it based on certain endpoints that we measure the patient's outcomes, and then based on the outcomes, patient is identified whether he is he's being eligible or for continuation, or if he received or achieved the endpoints, then we pay for the second installment. If not, the payment is being stopped, and by then we already have the access, we already get the innovative medication into our patients as well. And again, having the SMA registry and then the patient support program as well. So by then, I end my presentation. Thank you so much.